Well, good afternoon, everyone. On behalf of Precigen and our co-host at the RRP Foundation, I would like to extend a heartfelt thank you for joining us today for RRP Awareness Day. Building on the success of last year's event, we have brought together an incredible group of expert clinicians, patients, and caregivers to shed light on RRP and the community impacts. We are especially grateful to our moderator for guiding today's discussion, to our expert panelists for sharing their invaluable experiences and scientific perspective, and to our patient panelists, the honesty and resilience and their personal stories, which are truly the heart of these events. This day matters simply because RRP matters. It's a chronic, devastating disease. It's a rare disease with no FDA-approved treatment. And it has been, I heard stories that this disease, and I think our panel of physicians will speak to that unfortunately the treatments since 1800 has been known this indication, and they will speak to that and how in 21st century, the surgery is not going to be the treatment for this. And obviously it's caused by HPV 6 and 11, and this gap is unacceptable. And it's exactly why Precigen is committed to this fight. I would like to take just a minute to give a special thanks to the Precigen team that are here and are joining us via webcast for the relentless pursuit of finding new treatment for this. So I'm grateful to every single one of you. Awareness is the foundation of progress and innovation. By gathering here today, patients, physicians, advocates, scientists, we are not only raising visibility and building momentum. Together, we are driving the change. Thank you again for joining us, and I would like to hand it to Kim.
Thank you, Helen. On the behalf of the Recurrent Respiratory Papillomatosis Foundation, good morning, and thank you for being here. RRP Awareness Day is a global event. We currently, right now, have people all over the world tuning in. So I'd like to give a huge shout out to our international friends, our guests online, in person, each of you, and to those behind the scenes that made today possible. I want to open today up with Floor. I was recently in the Netherlands and was able to have dinner with the Netherlands patient group. And they gave me Floor. She is a representative of one of their patients named Floor. So today, she is representing all of us. Today, we are all Floor. When I first got this, I knew I wanted to do something with it, and today seemed like the perfect day. Floor represents all of our struggles, all the times we've gone to surgery, all the times parents have sat in waiting rooms watching that surgical update to know their child was now in the recovery room. Floor represents that 30-year-old, newly diagnosed adult onset educator who's wondering, what happens to my career? Floor represents the researcher who has spent countless hours in the lab trying to answer those questions about RRP that have driven us to where we are today. Floor represents the clinician who has to give that news to that new patient. No, surgery isn't curative. They have to tell that patient surgery isn't a fix. It's just a Band-Aid. All of them and so many more are the why we are here today. Today, though, as we begin to celebrate, we are here as a community to shout that we will no longer accept that a lifetime of surgery is an acceptable option for our treatment. Today, we are all Fluor, and we're here with a united voice, with a united goal, ending surgery as the treatment for recurrent respiratory papillomatosis. Today, you're going to hear from incredible patients, clinicians, and researchers about why we matter, why the work you're doing matters, why RRP and pulmonary RRP, why us having specific billing codes matters, why advocacy matters, why screening for pulmonary matters, why investment in RRP research matters, and most importantly, why one less surgery matters. It is my honor to be here. I am so grateful to Helen and the entire Precigen team. You saw us, you heard us, and you fought for us. Today also is a great representation of turning this diagnosis into a why. So with that, today, we're here to celebrate our progress, celebrate the stories, and celebrate all that's to come. And with that, I want to turn it over to Daniel Levine. He's the principal at Levine Media Group, and as well as part of Global Genes. Daniel.
Thank you so much. It's a privilege to be here and work with both Precigen and the RRP Foundation on this day. At first glance, if you think about the world of 10,000 plus rare diseases, RRP may seem a bit unusual in that it's not caused by a genetic mutation, but a virus. But once you get beyond that, I think you'll find there are a lot of commonalities that RRP shares with other rare diseases. This includes the diagnostic odyssey that patients often have to go through, the lack of an approved therapy to treat the condition, and the substantial burden and impact on the quality of life that people with RRP must live with. The panelists on this stage today are here to share their personal stories and talk about those things. And I think under normal circumstances, it can be difficult for someone with a rare disease to get up publicly and talk about the impact of that on them. But I think doubly so for someone with RRP, where your breathing and speech can be profoundly affected. So thank you so much for doing this today and sharing your story. I'd like to start with just a show of hands. How many of you, and I should say Amy at the end is a mother of a 19-year-old with RRP, she's a caregiver, but how many of you or your children took more than one misdiagnosis before finding out that they had RRP? And how many of you took more than a year to get an accurate diagnosis? Hi, Steve. How about more than 3 years? Any of you? So let's talk about that experience. Robert, what were the early signs of RRP that brought you to see a doctor and eventually get diagnosed?
First of all, I appreciate everybody being here to bring awareness to this debilitating disease. My story is a little bit unique because I was diagnosed at the age of 22 while serving in the U.S. Army, and I was in Germany. So I started out with having a raspy voice. They treated me for having a cold, cough, allergies, laryngitis. they finally sent me to an ENT when I was having difficulty breathing on one of our runs. The daily impact, I mean, let me give you an example. So while we were all up here before we started and you guys were all talking, and honestly, it wasn't even that loud, that background noise makes it very difficult for us to communicate with each other or anybody else. I mean, we're basically having to stand this close. We have to force our air out. So, I mean, it impacts us daily. I haven't been through a drive-through in like 25 years because they can't hear me. I was telling them that on the golf course, when I hit an errant shot, my buddies have to yell 4 because I can't do it. So it's just those things like that. I mean, we get anxiety, we get depression, we socially isolate when our voices start getting horrible. And honestly, I hate hear the sound of my voice. It drives me nuts. So, I mean, that's...
Let me ask William, how about you? What was your experience of getting a diagnosis?
My condition started when I was 7 years old, and initially they thought it was simply my tonsils, and they thought tonsillectomy would be the cure, but after exploring that for several months and then visiting other ENTs, it took approximately 1.5 to 2 years to be correctly diagnosed, but only when I woke up with a trach in my throat.
One of the problems with RRP, like a lot of rare diseases, it may present like a far more common condition. Petya, when you went to get treatment, did doctors take you seriously? You were a young woman. Did you feel like they were writing you off, or did they really investigate what was going on?
First of all, good afternoon, everybody here and online, and thank you very much for listening to our stories. To answer the question, I don't believe I was taken seriously. I was told that what I had was common. It was vocal cords nodules that eventually would go away on their own. I was in my late teenager years, and we waited for something better to happen. But actually, my voice was getting worse and worse. So it took 3.5 years or maybe 4 years to finally convince the doctor that I needed a surgery. He took a closer look and said, actually, this is not what I thought it was. It's most likely RRP, but we had to wait for the biopsy to come back. We just confirmed his prognosis.
Amy, you were running around from ER to ER with a young child. Your son was diagnosed at age 1, but what was it like? You know, did they write you off as a scared mom, or?
Absolutely, yeah. I took Denver to at least 2 ERs and to a couple of primary care visits. His vocal quality had declined. His cry was really soft. He was probably like 9 or 10 months old when his first symptoms started, and for a few months, we would be sent home with steroids, antibiotics, nebulizers that weren't impacting him or helping him at all. So I ended up finding a magazine of top doctors in Seattle and just started calling places. And one of the nurses eventually heard his stridor on the other side and said, "Can you come in today?" And we went into Seattle Children's, and he was diagnosed. His airway was about 90% occluded at that point, and we did emergency surgery that next morning.
So surgeries are the primary way that RRP is treated. It's not unusual for people to go through surgery after surgery. Vicki, you've had repeated surgeries. What is the experience like? Do you get local anesthesia? Is it general anesthesia? And is there a big recovery? What's the impact of undergoing these repeated surgeries?
Well, I've had about 6 operating room procedures under general anesthesia and maybe about 40 in-office procedures, laser procedures under local anesthesia. I'll have to say, when I'm not symptomatic, actually like right now, if I weren't in this particular forum and focusing on the disease, I would tend to forget that I even have an issue. So it's always a very disappointing surprise when my symptoms come back. It's like a part of you wants to believe that it won't come back, and so when it does come back, it like really hits you harder than it should because you know that you have this condition. So when my symptoms act up again, I almost become a different person. I go into patient mode. A lot of other things in my life get on the back burner while I figure out how to make an appointment. If there's travel involved, I set up the logistics, deal with insurance things, and then finally, getting the procedure. The OR surgeries for me are physically easier, but because you're just asleep during everything, but they're mentally harder for me. I get very nervous because I don't like general anesthesia. The in-office procedures, I don't get anxious about them ahead of time, and then when I have them, there's brief moment, a few minutes of very intense concentration where I just have to focus on staying calm because it's a little bit jarring. You have a laser, you have tubes going down your nose, and then a laser will burn off tissue, and you can smell the burned tissue. And then I recently started getting therapeutic injections as well, and that could be very painful, but it's over after a few minutes.
So while surgery is the primary way this condition is treated, some physicians have used off-label therapies. I'm curious, just by a show of hands, how many of you have received an off-label therapy? And do your insurance companies generally pay for this?
Well, when you're seeking care, you'll do whatever you have to. And I travel to Baltimore to get supplemental care that is now quarterbacking all my treatments, but you do what you have to.
But in your case, do they pay for the physician visit itself, or is there other?
No, I pay for the physician visits myself, cash.
And
my insurance won't cover it.
And travel as well, or is that?
And travel, accommodations, everything.
How substantial is your travel?
If I was to annualize it, approximately 3 to 4 times a year now, and do I regret it? No, because I'm receiving better care.
Steve, you're in the United Kingdom. Steve was unable to join us in person, but thank you so much for being available remotely. You're in a different healthcare system. Are you able to get access to off-label therapies?
Hi, first of all, thank you very much to Precigen and particularly for Kim for inviting me. Access to them is extremely difficult with the UK NHS system. I, at the moment, was supposed to have an off-label adjuvant therapy when I had surgery 14 days ago. But because of the difficulty with the situation with the system of getting permission from the hospital and then get permission from the finance people, it wasn't possible. They just couldn't get it done in time.
There are social impacts that can be very severe with this condition as well. Steve, you are an accomplished singer. You are a dancer, although I take it because of the difficulty in breathing that you can't dance as you might once have been able to. What is the social impact of this disease, and has it affected your dating life?
I'm expecting 5 people to start nodding now because I'm going to say massive, huge. There is, you struggle to have a social life because I think, as one of the panelists has already said, you need to be within 10, 15 centimetres of me to hear me. In fact, I'm known as Silent Steve. Normally I put that up as my Zoom name, but I'm so silent that social situations are impossible. I don't go there now. I do go to dance events, but I've had to get T-shirts printed up saying, can't talk much on the front, can dance a bit on the back, and even then people still don't understand, and they now avoid me because I cannot socialize.
And William, you talked a little about the social impacts of this condition on you.
You know, folks, I think everyone that deals with RRP shares a lot of things in common, and I think the social barriers that we face because of our inability to speak loud, or my wife and I were just arguing and just discussing, I love concerts, but I also hate concerts because I know as soon as I go to a concert, I'm not going to be able to tell my wife how much I'm enjoying this song or whatever it is. Similar to a loud restaurant. I'm a foodie. But as soon as I go into a loud restaurant, I start to just discredit the restaurant entirely because of the ambiance. When the food may be delicious, it's always on my mind. Meeting new friends, being described as an introvert when I think, in full transparency, I'm probably a little bit more of an extrovert. But 48 years has taught me just to stay quiet, don't call attention, and just mind my own business.
Well, you're a bit of an adventurer at heart, though. You've run with the bulls, you scuba dive, you travel extensively. What does it take for you to get physically and mentally prepared to do something like one of your adventures? And is there advice you'd offer other people with RRP who may be a little tame about taking on such things?
Yeah, I think we all can agree that being vulnerable is not easy. And as I prepared for some things, there's a mental preparation as well as a physical one. When I did the Inca Trail, even though I live in Salt Lake, Utah, where our elevation's around 4,400, I was training for months beforehand, going into the mountains, knowing that even my best training wasn't going to put me at just an average with the group I was going with. Consequently, going with 14 other guys, one of them was an ex-Green Beret, which didn't help the ego. I had to tell my guide that, and prepare him that I needed to leave about an hour and a half earlier than everyone else, which meant waking up earlier, sleeping less, taking off on the hike, and knowing that by 10:30, 11 o'clock, they'd be passing me by. And I'd be arriving about an hour and a half late to camp afterwards. So I received special instructions. I did the bulk of the Inca Trail by myself. I'm grateful, but you know, it takes a social toll. You just learn to be grateful. 10 fingers, 10 toes.
Robert, you used to work in law enforcement. I'm wondering what effect RRP had on your career and your ability to work.
Well, I was fortunate that the state of Oklahoma had to hire me as a disabled veteran. So they couldn't really hold my voice against me. So once I got my degree, so I started as a correctional officer. The inmates would call me squeaky, raspy. I mean, it gives you thick skin. Then I got my degree, went probation and parole, then I became a criminal investigator, and then a polygraph examiner. I was fortunate that, like when I'd have surgery, I have to have a 5-day, 7-day voice rest. When I came back to work, they would put me where I could review reports, investigations, until I could get my voice back to go into the field and do arrests. And I believe I had more surgeries probably than I needed to, because I needed to communicate to do my job. And I'm the type of person, I couldn't have my officers go out there and be on this arrest team if I'm not on it too. So that was difficult, but I was fortunate that I worked for the state. I got lots of leave, and they really worked with me. But it was also, I mean, you always have this fear in the back of your mind that if something does happen and you've got to vocalize, or you're going to be able to communicate, or somebody can get hurt, because of your lack of communication. So that was always in the back of my mind on that.
Amy, you're, as we said, a mother of a 19-year-old now, but what's it like to raise a child with RRP and to get them to understand that condition and what they need to do to take care of themselves?
It's been challenging in a lot of ways. I think initially when Denver was diagnosed, my instinct was just to be incredibly protective and shelter him from any social or emotional or physical harm. And I really, I think that overprotectiveness contributed to some anxiety all across the board. And so being able to kind of say yes to things has been a journey, and, you know, encourage him to go out there and be adventurous and do new things and try new things has been important in our lives. So yes to taking the 12-foot sailboat into the Puget Sound, and yes to driving as a 16-year-old into Stevens Pass to go snowboarding with his buddies, you know, and really kind of challenging myself to not lead with fear and anxiety and really support Denver and myself emotionally and mentally, as well as making sure he gets the physical care that he needs. And, you know, as a 19-year-old man now, I feel like I have taught him enough to, you know, check in with his doctors, and I'm still there to help guide that process. And I wish he would check in a little bit more. But yeah, it's got a lot of challenges, and that reality of Denver has had over 50 surgeries, and so that he would like to forget. He has been in remission-ish for a couple of years now. It's been a couple of years since his last procedure. And I think like all of the, like I think what Vicki said too, like when you're not thinking about it, you're not thinking about it. There's always that fear of, you know, waking up and your voice is starting to decline, and now I have to, you know, readjust what we were going to do if we were going to travel or go somewhere. Now it's, when do we get surgery?
And surgery is not something that patients run to and embrace. There's a fear, I imagine, of your son downplaying the seriousness of the problems he's having because of that. But William, you're a grown-up. I take it this was a problem with you as well.
Try imagining that you're breathing through a straw on a daily basis, a regular Coca-Cola straw. And as you're approaching, you know you're approaching surgery because now that straw is like a coffee straw where it's narrowed even more. So mentally, you try not to think about it, but it's there. It's there all the time, and it does impact what you want to do. We went to Havasupai Falls a couple of years back, and I should have had a surgery. And it's a 10, 11 mile hike in. Fortunately, it was downhill. But regrettably, to leave, it's 10, 11 miles up. And it was embarrassing. We were with 2 of our 4 kids, and I had to bargain with the locals to get us 4 horses because I couldn't do it on the way back. And I had the surgery. Would have taken me a while after I did the Inca Trail, but that was embarrassing. It was hard.
Steve, you referred to yourself earlier as Silent Steve. You used to work as an ENT, but today you're a chauffeur, and you've used your RRP as a bit of a branding experiment. But can you talk a little about that? Why did you do that?
I was using Silent Steve as my handle on social media already, and a very wise and very kind friend of mine said, well, why don't you use it commercially? And it's something I hadn't thought of before, but with the work I'm doing at the moment, Silent Steve works well because silence as in, if I'm driving somebody that they know that I'm not going to be chatting away to them, I'll only say appropriate things. Silence in that anything they say or what happens in the car stays in the car, it's silent, it's confidential, and also silence. We're getting on with things in the background. I don't know, sorting out the car, tidying up the car, filling it up, whatever it may be, even doing errands. So silent Steve is how I know. All my clients know me as that now.
So the panelists referred to the feeling of social isolation that can come with a condition like this. One of the interesting things to watch last night were people with RRP interacting with each other, and many people with this condition, short of getting involved with an organization like the RRP Foundation, may never have met another patient who has this same condition. And the information sharing that immediately took place was fascinating. But, it's, Vicki, what has being able to interact with other patients meant to you?
It means I don't have to go through this alone, and the other patients, they become something like a family to you. It's not really your family. They're not your friends who you see all the time, but you share one very intimate and rare thing, and you can understand the other person. So it's really helpful to have the community.
And Amy, would you have any advice you would offer other caregivers?
Absolutely. I think don't let fear be the only voice in the room. Build your team up, not just with medical professionals and experts, but really reach out to the RRP community, the foundation, and lean into each other. Make sure you're building up your emotional and social support as well. For me, what became important was learning not only myself and my son and the disease, but the pathophysiology behind it, pushing myself a little bit more. I went to school, became an RN, and I just I'm in school again. It's just, to keep learning and keep encouraging each other and to really build that team up.
We're going to open this up to a Q&A shortly, but before we do, I just wanted to ask, Robert, how can people in the room or watching, what can they do to help support the RRP community?
I think one thing they can do is get onto the RRPF website. There's a whole bunch of education, bunch of discussions on there. Just bring awareness. Tell somebody. Tell all your friends. Just point it out. You guys can, Presage is doing an excellent job with helping us get rid of some of our fears, I think, giving us hope. But you've just got to be involved. So.
And William, what would you want people to understand about this condition?
Echoing what both Vicki and Robert said, letting everyone know that with RRP, that there are non-surgical options, and progress is happening faster than I even knew. But explaining that there's a community out there, and fortunately we have a great leader with Kim, but that we're not alone. We do have a voice.
Well, let's open it up to questions from the audience. Is there someone with a mic? So, does anyone have a question for our panel? I have a question over here. So while he walks over there, what one thing, are you ready? Go ahead.
Hi, thanks for talking about your experiences. I guess I have two questions. In your diagnostic journey, what do you think might have helped accelerate that journey looking back now? And then second, I guess the question is how meaningful is, decreasing the number of surgeries by even a single or two surgeries? How meaningful is that to you as a patient?
You guys want to take this?
I'm not quite sure how my diagnosis could have changed, because back in 1990 when I was diagnosed, the doctors that I initially saw, they really didn't have a clue about this disease. So they treated me just for the symptoms. Having one less surgery would just be incredible. I mean, that might break that cycle of the anxiety, the depression, the social isolation. It also gives us hope that maybe, I mean, if we have one less, then we can have two less, then we can have four less. I mean, I've always grown up thinking, all right, you're gonna have CO2 laser with cidofovir till you die. And now there's hope that that's not what's gonna happen to me, so.
Are there any other questions? So she actually teed up our final question, which was, what would the availability of a therapy that could reduce the number of surgeries needed? But I'd like to put that to all of you, and just work our way across the panel, starting with you, Amy.
Yeah, I mean, it's life-changing to think that we don't have to go to surgery. I live in a rural town in Port Townsend, Washington, and so each surgery, we have to go to the city. We call it across the pond, because you got to take a ferry, and it takes 2 hours, and it's complicated to navigate that type of system, and one less surgery would be one less trip to do something not so fun in Seattle, and one less chance at having extra scar tissue that's going to affect Denver's vocal quality, or something go wrong in the OR. All the fear that comes along with surgical interventions, and there's a long list of them, and we talk about them all the time in our RRP community.
Betcha, how about you?
I mean, it'd be incredible. I mean, I've had over 100 surgeries in the last 35 years and been put under general anesthesia over 100 times. It would be incredible not to have 1, 2, 3 additional surgeries. I mean, it'd be an incredible thing for me.
Betcha?
It would mean more quality time with my family and my children in particular. We missed a lot of bedtime story times together while I'm recovering after a surgery, or why am I waiting for the next one? So that's something that I missed a lot. And now I'm teaching my son Bulgarian, which is my native language, but we have to interrupt our teaching schedule many times because of my voice.
William?
That's a heavy question. If I could trade one surgery when I was an adolescent to just skipping that, boy, it's priceless. I think something that gets overlooked is, at least with some of us, and I'm admitting this for the first time on stage, we suffer from PTSD. And with every surgery, it gets worse. And maybe because we're a father, a husband, a brother, whatever, a son, we don't want to talk about it. So one less surgery would go a long way.
Vicki?
I think like what Pet just said, I would have more time to enjoy my life and enjoy my family. I just realized too that I have 2 kids and I wasn't able to really read them bedtime stories, which kind of stinks because I really like reading. Thank goodness for audiobooks. And so it would just be one less thing to worry about, and I'd have more time to do other things.
And Steve, give you the final word.
Thank you. I think for me, any less surgery is better. For me, the hardest bit is the voice rest afterwards, which I'm actually supposed to be on at the moment because I've got post-op infection. Because RRP means you just aren't heard. But in the post-op period, you've got to completely and utterly isolate yourself from everyone, because in my case, I was told you must not even talk a word. I had to get permission from my surgeon to do this today. That's the hardest bit, the post-op bit. So one less time where I have to just not even talk to my mum at home. that would be a dream.
Well, with that, please join me in thanking this excellent panel for sharing their stories today. We have an impressive group of physicians who are at the front line of treating RRP who are joining us today and going to talk about the physician perspective as well as fill out some of the things you heard earlier from patients with a broader sense of patients with RRP. Let's start with Dr. Best. You're at Johns Hopkins. What are the most common symptoms that bring a patient to your office with RRP?
RRP is a disease that affects the vocal cords. Far and away the most common location for the growth of the papillomas caused by the HPV 6 and 11 virus is on the vibratory vocal cords. And when something is on the vocal cords and they cannot vibrate like they're supposed to, it causes a change in the voice. The medical word for that is dysphonia. So I would say the main symptom medically is dysphonia, or what patients would describe as a hoarse voice or a change in their voice.
And Dr. Le Boulanger, thank you for joining us from Paris. Dr. Le Boulanger couldn't be here today, but he's been kind enough to dial in. I'm wondering, you work with a pediatric group of patients. What normally brings a patient to you, and is it different in a healthcare system in France?
No, not so different. Thank you for having me tonight. Good afternoon for you. No. The same symptoms bring the patients usually, and as it has been previously said, usually they wait a while between the first symptoms, the hoarseness of voice and the shortness of breath, and the diagnosis. They wait several weeks or months between the first symptoms and the diagnosis itself.
And Dr. Pransky, you're a pediatric specialist. I'm wondering, are there unique challenges to working with a pediatric population with a condition like this?
Yeah, I think there are. We have the same issues that we heard from the patient panel and dealing with adults, which is that you have to take care of the patient. But in the pediatric world, you also have to manage the parents. And you need to educate them. You have to make sure that they have appropriate expectations, that they know what's down the line. And we heard from Amy about the issues in relationship to how she's going to manage her own life around her child's disease. So you need to spend a lot of time and a lot of energy teaching the parents and ultimately working on advocating for their lives with their children.
And do you encourage or discourage Googling?
I encourage awareness, and I encourage interaction with the community of RRP patients, working with the RRP Foundation, as we've heard earlier, because I think that knowing that you're not alone in this rare disease, in this non-predictable disease, and probably most importantly, this chronic disease, it's enormously helpful to know that there are other people out there who have going through the same experience.
Dr. Friedman, you're at the University of Cincinnati Medical Center. When you think about treating patients, do you have many options, and do you think about treatment for pediatric patients differently than adult patients?
Yeah, so my practice is adult patients. I have excellent pediatric otolaryngologists across the street at Cincinnati Children's. But in terms of treatment options, I guess the better term is management, right? Because we are really sort of managing the disease. And as you've heard before from many of our guests so far, surgery is really that main management strategy that exists for most patients. In the adult world, there is the option of treating patients in the office with awake procedures, but typically that's not where we start. We start in the operating room to debulk the disease, and when there are limited recurrences, we can sometimes manage those in the office. There are a few off-label therapies that have been alluded to as well too, and sometimes those can be really valuable management strategies, particularly when surgeries have to be very frequent or when there are places that are not surgically accessible.
And when you think about off-label surgery, off-label medicines, is a consideration the ability of a patient to get reimbursement for that?
I'm sorry, could you?
Sure. Is reimbursement a consideration when using off-label therapies?
It certainly can be. From the standpoint of insurance clearance, right, there's a logistical hill that has to be climbed from that standpoint in using many of these off-label therapies, yes.
Dr. Pei, you're at Yale. What would you say the current challenges physicians face in both diagnosing and treating RRP?
Yeah, I would say one of the challenges is the wide variability on how patients are treated. So oftentimes when a patient comes to see me, I have to dig through an exorbitant amount of medical records, going through trying to understand all the various surgeries and all the various treatments that they have. In addition, many of my patients come from out of state. So it's trying to coordinate as much diagnostic workup, operative visits within a 2 to 3 day window. So it is a lot of coordination, taking care of just one RRP patient.
Dr. Norberg, you're at the National Institutes of Health. I'm wondering what you see the current challenges being for physicians in treating this condition.
So one of the things that comes up is conducting clinical trials in order to test new medical therapies. And so as you can imagine, in a rare disease, it can be challenging to accrue enough patients in order to treat on the clinical trial to find out if that therapy is safe and effective. So, one of the things that's nice about the NIH Clinical Center is that we can help provide some of the costs, cover some of the costs that patients have to experience when, enrolling into clinical trials and traveling to a central location. So we can help with flights, we can help with housing, lodging, and the medical care as well.
I'd like to ask by a show of hands, when patients come to you, have they typically faced a misdiagnosis first? Across the board. And also by a show of hands, since surgery is the primary way this condition is treated, do patients express fear over these procedures? And finally, one more show of hands here. Typically, do patients have more than 50 procedures in a lifetime?
Yeah.
More than 100? Do you have patients who have had more than 300? Dr. Friedman, how do you go about building a care team for someone with a rare and chronic condition like RRP?
Yeah, I think it is evolving into something that is multi-specialty, sort of as you've alluded. I have the privilege of working in an academic center as a laryngologist, so as you've heard, voice is a huge component of this disease, so we work with speech pathologists that subspecialize in voice and can help our patients with the recovery and adaptive strategies. We also are collaborating with other specialists, particularly interventional pulmonologists for disease when it is extensive and extends down into the windpipe and even into the lungs. They're valuable colleagues in our sort of multidisciplinary management. And then also our medical oncologists and hematologists are increasingly becoming a part of this team with off-label therapies and with therapies that are in development pipeline now.
Dr. Brownski, how about you? When it comes to building a care team for a pediatric patient, is there different considerations, or being on your own office, is there a different process?
Care teams are routine for many diseases that pediatric patients experience. Being a rare disease, it's difficult to put together this core group of people that might see the patient on a regular basis. On the other hand, as the surgeon, the primary caregiver, physician caregiver for this, it becomes the responsibility to be an advocate for generating the team that's needed. So beyond what Dr. Friedman already elaborated, you have to begin with looking for the support services that the child and the family is going to need. So that begins with social work and navigating the system of the hospital and school and appointments and all of those issues. But beyond that, you need the speech therapist that actually knows about this type of a disease and what to expect, the variability in its presentation. You also need both psychological support You need to support the family in that regard, and certainly the patient. You have to manage school and the issues that take place in school in terms of participation within school, learning, bullying, understanding by the teacher, concern by the other parents about, well, maybe my child will get this. There are an enormous number of social issues that demand attention. In addition to which, you have to educate the primary care physician about what this disease is so they can also serve as advocates for the children. So that care team is very broad, and it's really up to the individual surgeon to make that happen.
Dr. Le Boulanger, is that different in France for you when you think about putting together a care team?
No, we share most of our procedures, and the organization is quite the same. First the ENT clinic, and then the multidisciplinary organization and team, the anesthesiology, the operating room, the fiber optic examination in the ENT clinic for the follow-up. I guess the main differences would be, first, France is a smaller country, so patients travel less from their home to the healthcare center. Perhaps the vaccine coverage is not the same, but I guess we might come back to that later. And one of the main differences is that healthcare is free, mostly free for this kind of disease in France. So patients and parents do not have to worry about that.
Dr. Pei, you're an expert on the pulmonary manifestations of RRP. Can you give a sense of how common those are, and how big a risk is there that a benign papilloma can turn into something malignant?
Yeah, so I think that really highlights how HPV infection and RRP is really a systemic issue in the upper aerodigestive tract. So really assessing disease burden requires you to assess disease below the vocal cords involving the trachea or the lungs, and up to 8.9% of RRP patients have lung involvement. And once it goes to the lung, there's a 32-fold increased risk of it turning into cancer. And even that, so they have a diagnosis of lung cancer, but because it's from a virus infection, sometimes there's different perspectives of how that lung cancer should be treated. And it really just highlights how we need to better understand how the cancer develops in these patients, what is the long-term prognosis, and really developing treatment algorithms that can be applied throughout the country so that it doesn't depend on where this patient is being treated, what their outcome may be.
So, Dr. Best, we heard about the repeated surgeries. You've done some research into the potential damage that can happen from the repeated surgeries. I'm wondering if you could talk a little about your work there.
Yes, RRP is a chronic infection. And that's the way to think about it. It's the way to conceptualize it. And so we are not curing this disease with surgery. I think Dr. Freeman saying we're managing it. We're just managing it with surgeries and debulking the papillomas that affect the voice and the breathing. Consequently, patients have had many surgeries for this condition, as we've heard, up to hundreds. It's not uncommon to have patients who have had more than 100, 200, 300 surgeries for this condition. As you can imagine, the toll that takes on the vocal cords is substantial. The vocal cords, the vibrating structures in our throat, are a centimeter, 10 millimeters. Imagine 100 laser procedures on the vocal cords. So it's no surprise that as you have more and more surgeries, you accumulate a higher and higher chance of having permanent voice issues. We looked at our series at Johns Hopkins. We divided patients into groups. The least severe group, patients who'd only had 5 surgeries. Imagine another condition where you could say, well, I've only had 5 surgeries for this problem. Those are the least severely affected patients. 40% of them had permanent communication issues related to surgeries. By the time you'd had more than 10 surgeries, which is a very large percentage of papilloma patients, 97% chance of having permanent vocal cord damage as a result of the surgeries that we've done.
So Dr. Pei touched on a link with cancer, but Dr. Norberg, I'm wondering, you are at NIH's Center for Cancer. What is someone who works in a center for cancer doing studying RRP?
Yeah, it's a great question. So I have an interest as a medical oncologist in HPV-associated cancer. So when I started working with my colleague there, Dr. Clint Allen, who is a senior investigator that also has an interest in HPV-associated cancer, we were able to see the ability to leverage the knowledge that we have developed in understanding how to treat and the pathophysiology of the disease and how that could potentially be used to understand and potentially treat RRP. The other thing that, as I started to conduct clinical trials in this space, I really realized that there's a lot of similarity in the sense of the patient population, and that I treat a lot of patients with incurable cancers. As you can imagine, there's a lot of despair, not much hope. And when I interact with our patients with RRP at that time, that's really what the sentiment was. And so I had a lot I could relate to that patient population. And so it's something that I've been very blessed to be a part of, to be able to help out the patient population.
Dr. Friedman, what are some of the unique challenges of studying a disease like RRP that's rare?
So rare diseases in general, just by their definition, are going to be fewer patients in general to be able to correlate. And there's a lot of variability, as you heard, in patients with this disease too. So I have patients in my practice who fortunately may need operations maybe once every year or two. And then there are other patients who have had, as other colleagues on the stage have said, hundreds of surgeries and are needing operations over the course of every 3 or 4 times a year. So I think that variability makes it hard to really sort of say that one particular patient's journey is going to be the same as another patient's journey. I do think in general though that when we have collaborations amongst researchers and colleagues in a patient organization that is creating a voice, it makes that study of that disease easier, right? Because we can pool data, pool patients, and collectively sort of move the field forward.
And Dr. Pei, would you say there are other unique challenges?
Yes, I think in a world where there's limited resources, I think funding of research related to rare diseases like RRP can be challenging. In addition, when we're talking about clinical trials, does the RRP trials fall into the cancer center, or does it fall into the normal non-cancer clinical trial infrastructure? So, you have to get buy-in from the cancer center to utilize their resources to run RRP clinical trials.
Dr. Norberg, given the impact of repeated surgeries, what would you say the need is for some therapeutic intervention that could minimize that?
Yeah, so at its core, as we all kind of talked about, RRP is a medical disease. Surgery has been used as really a temporizing measure in order to palliate the symptoms of shortness of breath and voice disturbance. So development of medical therapies requires understanding of the disease, scientific innovation, and really until that has moved forward, will we be able to treat RRP really as it is, which is a medical condition.
And given that the underlying cause of this disease is fairly well understood, how many of you would like to see therapies that can address the underlying cause rather than symptoms? RRP is caused by the HPV virus. We do have vaccines for HPV. What is the role of vaccination in RRP? Dr. Boulanger, you want to start?
Yes, sure. Thank you. Thank you for this question. It has been shown quite well now that vaccination prevents the aparition of the disease, at least if not totally, mostly totally. So it's very important to vaccinate young people in order to avoid the aparition of new cases of RRP. Well, I don't know the exact numbers in the US, but France is quite a bit late in the EU regarding youth vaccination. Late 2024, at least 50% of the girls had 2 doses and 25% of the boys had 2 doses of vaccine. So we are working on it, but vaccination is very, very important in order to avoid new cases, yes.
Dr. Friedman, how about you? What role does this play in prevention?
So prevention is again, the key word. The vaccines that exist do not treat people that currently have the disease, but the idea is to have fewer people developing the disease. And there's been a push in the United States for these vaccines to be given in a broader swath of the population. There are, of course, all the drawbacks that some people see to vaccines that apply to this as well. So there's hesitancy on the part of patients to obtain it. One of the other things, though, that's been a great change in that is the age sort of range that is approved for the vaccine. And again, just to be clear, this vaccine is really designed to treat and prevent HPV-related cancers, but it has the benefit of also treating RRP because it covers some of the same viral subtypes that cause RRP. But the FDA has expanded the age range. I believe it's now from 9 to 45, so that more people in the United States can receive the vaccine and have it be covered by insurance.
And Dr. Pransky, are there special challenges to getting people to use this vaccine?
One might consider the concept of vaccines a little bit of a hot topic these days. There is resistance, and part of it, management is first by actually educating our pediatric colleagues who are the ones that are administering the vaccines so that they understand the importance of it. I think helping the patients in general to understand how ubiquitous HPV disease is and that this is indeed a cancer vaccine that is an incredibly safe, incredibly effective, that an enormous amount of research has gone into it. And for parents who recognize that this is a sexually transmitted disease, understanding that giving a vaccine is not giving their 15-year-old permission to have sex. It's a little bit like saying, if you wear a seatbelt, then you can go and get in a car crash. So that it's a whole series of issues that take place to convince parents to vaccinate and to vaccinate before the age of 15 for a variety of reasons in terms of only needing to have 2 versus 3 vaccines prior to sexual activity is critically important. So there's still work to be done in the United States and other countries. There's been incredible success in essentially eradicating papillomatous disease in places like Australia, where vaccination is virtually 100%.
Well, we have a little time for questions from the audience. If anyone has a question, just raise your hand. We have a question over here.
I would just like to add to this, Dr. Pransky's comment, that reiterate that how ubiquitous HPV is. And I don't think people realize, the vaccine, the virus impacts women, but also impacts men, causing HPV-associated head and neck cancers. But then it also impacts the children who are getting exposed in utero. So it's just, there's, such a broad potential impact of receiving the vaccine.
Is there another question that someone has for the panel?
I do have 2 questions that were written in from people attending virtually. The first is, if someone is born with RRP and they grow to continue to have the symptoms, can it be transferred to their partners?
That's a great question.
Anyone want to take that?
Yeah. Well, I believe that people with RRP have infectious virions, so I think they're constantly creating reinfection in the local environment. There haven't been any studies to show transfer from partners. That would be an interesting study. Even seeing if the partner has antibodies against the virus would be interesting.
You had another question from the audience? Oh, I'm sorry.
Dr. Best, you're going to...
Yes, if I could just follow up on that. We have a lot of patients with papilloma, and I've never seen a partner also have the disease. I think this gets to the fact of what Dr. Pei was saying, is that the HPV viruses are actually very common in the population. There are very good studies that show if you gather a group of people and you have them spit into a cup, 7% of the population at any given moment has HPV in their saliva. 7% is a very, very large percentage. So the mystery of RRP is why so many people are exposed to the virus and only a very, very tiny fraction end up with the chronic infection. And that chronic infection and why it's allowed to persist is the problem that we're trying to address scientifically and clinically with new treatments.
If I can elaborate on that just a little bit as well from the pediatric side. For the numerous number of patients that I've cared for and my colleagues have cared for through the years, siblings have not gotten the disease from them, and despite the fact that there's this enormous amount of contact. And we know there's some form of immunologic dysfunction that permits this disease to occur. There have been studies done that have tested newborns showing that as many as 25% of newborns have evidence of having been exposed to HPV, and yet the number of children that are ultimately diagnosed is minuscule in comparison to that.
Yeah, to add to that, 90% of people are able to clear the virus within 2 years, and it's only 10% who aren't. And to speak to what Dr. Bez and Dr. Pransky was saying, there is known susceptibilities of HLA expression in patients with RRP, so that they do have immune cells which are not able to appropriately clear the virus, which may increase their susceptibility to developing RRP.
Anjali, I see, please.
To add one thing, we follow one boy who has an homozygous twin, so two boys, and one has the disease, not the other. So the genetic part of it is still unclear.
Yeah, at Johns Hopkins, there's a pair of identical twins. One has it and one does not.
And we have time for one last question, though.
This question is, any potential treatments on the horizon to help repair vocal cords that have been damaged from multiple surgeries?
Yeah, that's a wonderful question, actually, because if you think about the patient group, like the patients that have this disease, and imagine what they've been through, it's a group of warriors that at the end, if we do find a cure or a way to alleviate the need for surgery, they will have been left with the scars, physically and mentally, of what they have been through, what we have put them through. And the hope is for vocal cord regeneration, for new technologies, stem cells, to help recover vocal cord vibration and vocal cord function. Because you can imagine a world where RRP is cured, and we have tens of thousands of people who are still debilitated and need vocal rehabilitation and vocal recovery. And that is the next frontier. I actually truly believe that when we see a cure for this disease, we then have the next phase, the phase of helping people recover from what they've been through.
So we have to wrap up now, but as we wrap, I want to ask each of you in a sentence or a word just to say, what led you to focus on RRP, starting with Dr. Pransky?
So I had the fortune in my fellowship back in 1984 to be involved in the initial major study using interferon as a treatment for this disease. And then through the years, not only became interested in it, started to do research and published on the first publications on treatment of children with cidofovir. And fits and starts and stops, and 30 years later, we're still trying to look for that cure. So the journey has been one of, as we heard from Scott, in terms of dealing with this devastating disease process for the child and for the parents, that became just something that I wanted to devote a good portion of my career to.
Dr. Best?
Well, Dr. Pei is sitting right next to me, who I was trained under Dr. Pei, who is a world expert on HPV, and I was interested in the voice and voice function. I said, well, this is a combination of my two interests, and it really is the most rewarding patient population you could possibly imagine working with, because there's such a need. They need our help. They need everyone here's help to come up with better treatments for this disease.
Dr. Pei?
Yeah, for me, it was the patients. The patients came to me seeking whether any of the treatments I was looking at for HPV-associated head and neck cancers could be applied to RRP patients. So it was really the patients who drew me into the RRP field.
Dr. Norberg?
Yeah, and the same. Again, studied HPV-associated cancers. There was a lot when it came to understanding the disease and how we can help other patients suffering from other, virally associated conditions. But again, I think what also drew me in is the patient population and really seeing the struggles that you go to and the struggles that I see in patients that have incurable cancers. The lack of hope that there's something that can actually help them. The despair that they go through. So it's a really helpless patient population, and so it's great to be able to help that.
Dr. Freeman?
Yeah, my answer pretty much echoes what all my panelists have said. I can remember one patient in particular during my training as a resident who was in his teens and had 300 surgeries, and every resident in our program had operated on that patient. And as I was operating on them, I said, there has to be another way, right? This just can't continue. So it's really amazing to see the field moving forwards in a way that we're really excited about.
And Dr. Le Boulanger, I'll give you the last word.
Well, thank you very much. I agree and share what has been said. Just like to add, it is the occasion and the opportunity to give hope to both parents and children.
Well, please join me in thanking this extraordinary panel of physicians. I'm going to ask you guys just to stay seated one moment. I'm just going to ask Precigen CEO Dr. Helen Sabzevari and Kim McClellan, the president of the RRP Foundation, to come back and just close us out. But thank you all.
Y'all, what a day. To our panelists, especially to these guys, esteemed clinicians and researchers, thank you. Thank you for seeing us and for believing we were worth more than surgery. I will forever be grateful to know that my story will not be the story of the patients diagnosed today. It ends with me. And for that, I am so grateful. So I'm fixing to lose it up here. But again, from the bottom of my heart to the foundation, thank you for trusting me to do this. To Precigen, thank you for everything. Y'all have a rock star of a leader, and I can only dream to be just a fraction of the fighter that she is.
I don't know what to say following that, except for us, this has been a journey together with Kim and the patients, and a really incredible group of physicians. I am personally grateful. I have been in this field of immuno-oncology and immunotherapy, and my mentors are here. And it's really nothing. I always go back to the fact that 20 years ago I was told, you have cured enough mice. What are you going to do about the humans? And I think there are moments like this, standing with seeing what the patients need, incredible leader, and incredible dedicated physicians, which I have been privileged to be able to work and collaborate, and our teams, and also a very dedicated Precigen team that for them, it has been really relentless. We have seen what the patients go through. We understand it, we try to live it every day, and we try to really equip an incredible group of scientists, clinicians, and leaders in the field to make sure that they have everything that they need to really change the paradigm for this disease. So you have that promise from us, And we will do everything in our power, absolutely. So I'm grateful to every one of you, and I'm grateful to all of you for dedicating all of your careers and life to really, for treating this devastating disease. Thank you.